It's my pleasure to welcome you for this second day session, and we are glad that almost everybody is here, and I wish to welcome those who have showed up for the first time today, and we thank those who have been with us since yesterday, where we had a very serious engagement and discussions on serious issues in the HIV response. Let me introduce myself. I myself am Samuel Sumba. I work with Tanzania Commission for AIDS, and we are currently based in Dodoma. So I'm here basically representing the Chief Executive Officer, who was supposed to be here, but he got into other commitment that he really managed to be here with us. But otherwise, I had wished to be part of this meeting because of the importance this meeting brings to the HIV response. And I've been given the privilege to be chairing this session today. So I will be the chief in command, but I'll be assisted by the co-pilot there. So two of us will be navigating through the cloud today, and I hope we'll be able to fly you safely. Thank you. Are you aware this is a very important meeting as it tries to catalyze and strengthen but also improve the collaboration in the HIV response. So all the issues that we have been discussing since yesterday are very critical, and we hope that the recommendations that we will be making in this meeting will be helpful to improve the way our programs are being implemented in this country. Of course, with the focus to reduce infection, but also reduce AIDS-related mortality, and as we said yesterday, we wish to get zero stigma discrimination because they have a very significant effect in terms of the HIV response, and they affect both service utilizations but also treatment outcomes for those who are on treatment. Yeah, for this session, we'll be focusing on presentations, panel discussions, and we'll be actually speaking about stigma discrimination almost for the World Day. Sorry. And in the afternoon, we are going to work together to identify key concrete actions, measures required to put in place in the next 2 years to support addressing the HIV-related stigma discrimination. We are therefore looking forward to be getting much more presentations from the team of speakers who will be making those submissions later in the course of the day, beginning this morning and moving forward till late in the session. Specifically, if we go back to the program, I will begin with the presentation on addressing stigma and discrimination, the time for action. And we'll have presentations from 2 speakers. But thereafter, we'll break for tea. And I can promise you the session is going to be a little bit lighter, not as intense as it was yesterday. We left over a little bit late. So today is going to be a little bit lighter. And then we'll leave early. But also we're going to have panel discussions. And specifically, we'll be looking at the strategies to address stigma and discrimination. This will be actionable recommendations that we hope will be taken up by all key stakeholders that are involved in the HIV response. And then we break for lunch from around 12ish to 30ish. That will be an hour. And we also wish to have a group photo, actually to give an opportunity for those who were not able to be with us yesterday. So we're going to have another one today before lunch. After lunch, when we come back, we'll go into groups, just like what we did yesterday. There will be questions and people will be given time to go through those questions. But also, for those questions, we wish to come up with very specific recommendations or the so-called actionable plans. And then we have the action plan summary and steps identified. And thereafter, we're going to have the closing remarks. But I'm told that all the presentations will be available online in the next few days. The organizer is working on that arrangement, so be assured that you will have time to access those presentations. But it will also be recorded. And a workshop report will also be provided online. So having said that, I wish once again to welcome you to these sessions, and I hope we are going to have a very fruitful discussions and deliberations on various issues, specifically focusing to address the issue around stigma and discriminations in this country. Having said those few remarks, let me now welcome my co-chair to introduce to you the first presenter. Karim. Okay.
Thank you. Thank you, Mr. Sama. Good morning, everyone. Habari za asubuhi. My name is Abdullah Tereza. I work with Positive Society Tanzania. It's a network of MSM living with HIV in Tanzania. And I'm now pleased to invite our first speaker of the day, Josephine Nakubeni. She's an IAS Governing Council representative for Africa based in Uganda. She's also a youth program coordinator at Makerere University, Johns Hopkins University Research Corporation in Uganda. Welcome, Josephine.
Thank you so much. Thank you so much. Is it on? Okay. Good morning. Oh my God, yes. So, is it cold? It is, eh? Okay, maybe someone can turn down the AC. Maybe. We are Africans, please. So, I'm going to talk about, I'm going to summarize what happened during the AIDS 2022. And in particular about stigma and discrimination, because that is the main topic that we are really going to discuss today. But also it is one of the things that kept on coming up from yesterday's discussions, both from the panelists and also from the speakers. So when we say stigma, below we have around 3 definitions that are coming in from different people. And the first definition is stigma is an attribute that is deeply discrediting. If someone has been stigmatized, they feel discredited because of the act that has been taken place. The second definition is that it is the co-occurrence of labeling, stereotyping, separation, status loss, and discrimination in a context in which power is exercised. In most cases, when someone has been stigmatized, the person stigmatizing has some sort of power to prevent this person from either accessing services or from even expressing themselves as individuals. And then lastly, stigma functions at the intersection of culture, power, and difference. So stigma and discrimination usually go hand in hand. Like, one is a result of the other. Stigma is the negative stereotype, and discrimination is the behavior that results from that negative stereotype. So when we say discrimination, and when we talk about discrimination, we mean that it's unequal treatment of otherwise similar individuals due to their ascribed membership in a disadvantaged category or group. For discrimination to take place, the discriminated individual or group must be treated unfavorably compared to others or compared to another group. So there should be some sort of similar, or some sort of way that people should be taken or people should be associated with. But when this diverges from a certain individual or a certain group of people, then that is what we are referring to as discrimination. So you may be wondering, why are we really minding about stigma and discrimination, like since yesterday and the whole day today? So we do mind about stigma and discrimination, especially if that is related to HIV, because if it is not dealt with, if it is not worked upon by 2030, those are just like 8 years from now, we will have or we will lose around 440,000 people. I mean, this is a number that you may look at and be like, yeah, that's a number, but these are people that we are talking about. It could be me, it could be you, it could be a relative, it could be a friend, it could be your child. So in case we don't do something about stigma and discrimination, we are going to lose such people. And then also, we cannot achieve global or regional or national HIV targets unless we address stigma and discrimination, because it will affect, and it does affect, the way people receive services and the way they respond to treatment. And then experiencing stigma and discrimination is a negative experience that is very detrimental to mental, physical, and the quality of life that one is going to live. Trust me, to some of you that have experienced it, including myself, it is an experience that you do not want to experience again, or you don't want a loved one to really experience in their lives. And then it can definitely lead to depression, social isolation, decreased condom use, delayed HIV testing, less attendance at health facilities, and also reduced adherence to ARV medication. And we all know that if all these things are not met, we cannot meet our goals of 95, 95, 95. So what then? I mean, we've known what stigma is. It is happening in the world. It is happening in Tanzania. What is IAS doing about it? What are the other organizations going to do about it? So there is a very strong global commitment to eliminate HIV-related stigma. And indeed, the IAS is doing something about it through the Heart of Stigma. We all have these balls on our tables, right? Okay. So on the ball, at one side it has IAS, but then at the other it has hashtag the Heart of Stigma. So through getting to the Heart of Stigma project, the IAS seeks to facilitate effective and sustained change to reduce HIV-related stigma at scale, but strengthening the global and localized evidence base and catalyzing communities to practice by engaging diverse stakeholders. We cannot do it without involving every stakeholder that is needed to be involved. And then stigma and discrimination has also been recognized by UNAIDS as one of the major impediments to the HIV response. And then it was also identified at the 2022 International AIDS Conference as a cross-cutting major challenge in ending AIDS as a public threat. And then it is imperative for policymakers, funders, communities, healthcare professionals, and individuals to work together to mitigate and reduce stigma and discrimination in order to end AIDS as a public threat. As said earlier on, if we are to do anything around stigma and discrimination, it will call upon all our efforts, whether a policymaker, or a health worker, or a caretaker or guardian, or you're the individual receiving care and treatment. It will ensure that all our efforts come together for us to ensure that we end it and we contribute to our targets in 2030. So I will request each one of us to get involved. If you're here and you're not a member of the IAS, I'll request that please join the IAS network. There are so many benefits attached to being a member in the IAS. And if you have questions about membership, please you can reach out to Joanne and Laura, myself and Kenneth. But also being a member gives you the platform to also participate and get involved in some of these drives that are targeting to reducing stigma and discrimination. And definitely one of them is the Heart of Stigma. Thank you so much.
Okay, thank you Josephine for this interesting summary, and thank you participants for your, thank you Josephine for interesting summary, and can you remain there please? And now I would like to invite participants, if you have any question to Josephine, towards to presentation, you can raise up your hands, and we are going to take few questions. So if you have any question, comments, you can raise up your hands.
Comment to add for those that attended IAS, whether virtually or in person, you can also add something, because this is just a summarized presentation about what we did towards stigma and discrimination. And if you have questions, I welcome Laura and Joanne and probably Kenneth to also participate in answering them. Thank you. No question. That means I was too good or I wasn't too good.
Good morning, everyone. Thank you very much for presenting such succinct and good summary. I was very keen when you started the presentation, and maybe I missed the point, but I actually wanted to get out of you what has been the issue with getting this sorted. Because since the time of reproductive health, use of contraceptives and so on, stigma and discrimination used to be an issue, and it continues to be an issue. So when you started talking, I thought you would come up with maybe about one or two key things that makes it, let me say, a stubborn challenge to healthcare. Thank you.
Thank you so much. That's a good one and a broad one. I think today is really dedicated to stigma and discrimination. And during the panel discussion that will be happening after the break time, we are really going to be looking at the strategies or the recommendations on things that we can really do from different levels, national level, individual, health work level, on what can be done really to ensure that we reduce stigma and discrimination, specifically in Tanzania, because this workshop is happening here. Yeah. Maybe probably by the end of the day, the question will be a bit answered, and it will be upon us, people in this room, to ensure that we put the recommendations into action.
Okay, thank you for the nice summary. My name is Dr. Ivan Singay. I work in Tanzania. I was the participant of the AIDS 2022 video, and I want to just give a summary on the topic I was just summarized. One of what I called during the conference, discrimination and stigma are centered on our governments. They don't recognize those marginalized individuals such that there are no protective laws that protect those who have been marginalized. So as it is the time for action now, those who have been termed as criminals, now we have to decriminalize so that at the end of the day we legalize so that we protect and we alleviate the so-called stigma and discrimination. Thank you.
Thank you so much.
Thank you. Mine is not a question, but I just want to pose the challenge to participants, scholars, researchers, and all community advocates against stigma and discrimination. When you speak to the recipients of care, they talk a lot about stigma, particularly at health facility setting, coming out from the health staff, service providers at community level. And when you go to the facilities and speak to the health staff, you don't find those evidence. They tell you it's all about self-stigma. Now, there are two things which I want to get out of you, whether today or later on, which is the best tool to generate the evidence which keeps the balance about the truth around stigma at facility level and what needs to be done, which of course we'll discuss later. But again, who do we need to believe? The recipient of care or the service provider? And perhaps later on we need to discuss how we can balance the evidence that we are presenting without discriminating or devaluing the felt stigma and presentation coming from the recipients of care. Thank you.
Thank you so much. I think we need to listen to everyone. But we need to also really focus on the recipient of care, because they are the ones that are receiving the care. And they know the experiences that they are going through at the health facility. I don't think a health worker can evaluate themselves. The recipient of the participant in care will evaluate the health worker. But also be mindful when we say stigma in the health facilities, it is not mainly just coming in from the health worker to the recipient of care. Sometimes it comes from the clients at the facility, and I've witnessed this personally. You go at the clinic as a young person, and before you know it, the older people start asking you where you got the virus from. And you are in the waiting area, for heaven's sake. So that kind of stigma is not coming in from the health workers, it is coming in from the other clients that are actually waiting in the same room with you. So, those are still things that we can only capture if we hear from the client themselves. But I think we need to listen from everyone.
We don't have lights here. But
okay. Is there any question, please? Question, comment? No hand there. Okay. Thank you, Josephine, and thank you, participants, for your questions and comments. And now I would like to invite our second speakers, Bernard Kivuma. Bernard Kivuma is a researcher, officer, and medical doctor from the Ifakala Health Institute whose research interests are HIV/AIDS and sexual reproductive health and rights and key vulnerable population. He's also an IAS HIV researcher for Cure Fellow 2021 and IAS mentee under the HIV vaccine membership program. He also served as the executive director for Imarisha Foundation, organization that focus on improving the quality of life for transgender diversity personal living. Welcome, Ben Kigoma.
So thank you, Teresa, for that introduction. I will just go straight to the presentation. Also, thanks to Josephine for giving us that introductory summary about stigma. I think it has contributed in making my work a little easier. So today I will just be talking about internalized stigma among people living with HIV. And this will be a two-part presentation, where the first part I will just talk about a brief summary about what internalized stigma is, and in the second part of this presentation I will be presenting about a study that we undertook in Ifakara to attempt to address these issues about stigma. So I will just start with sharing a brief case that we saw at our clinic, and this is a case of an 18-year-old female client. That was a sex worker with no prior knowledge of HIV prevention, was diagnosed with HIV at our clinic and was willing to start treatment and was prescribed ART. So upon her subsequent visit at the clinic, she presented with an ART bottle that was damaged underneath the surface. And we figured out that she was trying to hide these pills because she didn't want her friends to know about her status. And the pills were hidden in a cow barn, so it was destroyed by being bitten by animals. So it led to the spill out of the pills and the loss of the pills. So I think this is one way that we see stigma being presented in the sense that patients are afraid to keep their medication at safe spaces because they are scared that someone might find out that they are using this medication. And the basic definition of internalized stigma is self-stigma, or that is another terminology for this, which occurs when a person either cognitively or emotionally absorbed stigmatizing assumptions and stereotypes that come from the people surrounding them. So one of the other common practices that we observe that is usually also an indicator for stigma is that we see patients coming to the clinic with bottles of ART that are stuffed with like papers or some sand, just to make sure that the bottle doesn't rattle when they are walking with the bottle, like producing this kind of sound when you're walking with the bottle. So they stuff it with the papers and stuff to avoid this sound. And this is spread by the so this is one of the ways that internalized stigma is manifested, how we see it at the clinic. So mechanisms of stigma don't only involve people who are infected with HIV. We also see people who are HIV negative, but they also have internalized stigma about a person who is living with HIV. So this is just a brief overview of the mechanisms that stigma can manifest, and we can see it in HIV uninfected that can manifest in terms of prejudices, which are judgments about people living with HIV, and also certain stereotypes about who these people are, and discriminatory attitudes toward people living with HIV, and the outcomes that are seen for people who are uninfected with HIV is social distancing, that means separating themselves from people living with HIV, also kind of slowness when it comes to like HIV testing, wanting to know their status, and low support for certain policies that are aimed to address HIV stigma. And this also tends to interact with the kind of stigma that is faced by people who are infected with HIV, which we see a stigma that can come from the external assumptions from people, which is also known as enacted stigma, and we also have anticipated stigma, which is the kind of stigma that you look forward to be experiencing. You haven't yet experienced it, but you're walking and looking over your shoulders, not sure whether people will have discriminatory attitudes toward you or not. And we also have internalized stigma, which I've already covered in the definitions of this presentation. So the outcomes that we see in people living with HIV include poor mental health, also lead to social support, and also HIV symptoms. So patients can come with advanced HIV or can present late because of these mechanisms of stigma. So the consequences of stigma, why we want to address stigma, is because we want to ensure that there is a continuity of care in HIV service deliveries. So we know that the way that HIV care is organized in components that are interdependent with one another, which include steps that a person takes from the initial diagnosis through their successful treatment and HIV medication. So what stigma does is that it breaks this chain just right from the beginning of the chain. Upon the diagnosis of the patient to the stage of being linked to care. So when we break this chain, it means that we cannot make sure that our patients are suppressed, and we cannot make sure that our patients are living, taking HIV from like this dangerous disease to like a chronic illness that is manageable. So we also see new HIV infections because of just failing to address these issues of stigma. And there's a study that was undertaken at our facility in Ifakara in 2017. It showed that the linkage to care has been reported to be 23% in patients who were diagnosed with HIV through home testing. So this is one of the reasons that informed the interventions of this study that I'm about to present next. So, going to the study presentation, this is the background. So we also talked yesterday about 95 goals from the UNAIDS targets, and one of the main things that we want to do with addressing stigma is to take a look at the second 95, which means starting on ART treatment. So there's a challenge in terms of loss of patients at all levels of HIV care continuum, especially in the second 95, because of the stage of linkage to care, which is broken by stigma. So one of the reasons of poor linkage to care is the HIV-related stigma and discrimination. So the study that we are undertaking at Ifakara is called the Stick to Health study, which basically involves stigma-related services to improve linkage to care for people living with HIV in rural Tanzania. So this was a pre- and post-implementation study within the Kilombero and Uranga antiretroviral cohort. The summary of this study is, I'm using this model to summarize this study. I think the researchers in the room are more familiar with this, so in case you don't get any terminology, feel free to ask me during the question and answer session. So the population is the Kilombero and Uranga antiretroviral cohort. This is one among the biggest cohort HIV positive patients in Tanzania, if not the biggest. We have about 6,000 patients who are actively participating in our prospective cohort. So the intervention that we are doing at the clinic involves a band of stigma-related services for newly diagnosed HIV patients enrolled from the 1st of February 2020 to the 31st of August 2021. And these are a band of services, which means that all these services are dependent on one another and they are delivered at different times when the patient is attending at our clinic. And these include post-test counseling, which is done by a HIV positive lay counselor upon the diagnosis of HIV, upon the reception of the diagnosis of HIV. And one of the aims of doing this post-test counseling is to also assess the levels of stigma and discrimination and depression also through questionnaires, which include the PH29 questionnaire to assess depression and the Vegas questionnaire to assess the stigma. And another second intervention is the post-test video-assisted teaching. So this post-test video-assisted teaching is about a 10 minutes video that is usually shown to a client who is newly diagnosed with HIV at our clinic. And this video is I won't share the video because of the time, but basically the description of the video is that we have a person who is HIV positive talking to other people who are also living with HIV, discussing about issues of stigma, positive living with HIV, and the importance of taking your medication, and also showing about the daily activities of a person with HIV that are normal just like anyone else, and to create like this common and relatable story that anyone with HIV is able to live a positive life just like anyone else. And also we have the third intervention, which is the group support therapy and group health education, which I'll go through it briefly at the next slide. And you have mobile health. So mobile health is when we call patients when the dates of their clinic visit are closed to remind them to attend their visits on time. So I'm going to the third part of the group support therapy. So the group support therapy, the way that it's organized in daily sessions that are delivered from Monday to Friday with different topics in each day and date. So these are organized, the visits are organized in a way that it doesn't interrupt the clinic visits of the client. So it means that when the client comes on Monday, for example, for the first session, they will come for the second session when it's the appointment date of the next drug refill, to make sure that the interventions don't interrupt the client flow, because this might also be having an issue with compliance to participating in these interventions. So the things that I discussed in the first session include how to integrate the diagnosis of HIV in one's life, which we talk about the issues of what is HIV and what is AIDS. In the second part of the group support therapy, we just talk about how does someone picture HIV from their own understanding. So this is organized in a way that to get to see the internalized stigma that a client with HIV might be having, and to also attempt to address HIV transmission and prevention. So the third session looks at what are the emotions, depression or coping mechanisms, and how does a client solve personal or interpersonal problems. So this also tends to look at the interactions with other people, and we tend to insist on the use of antiretroviral, as well as talking about the side effects and drug interactions, and why do we need like annual labs test for people living with HIV to make sure that they are also on the same boat with like the clinicians at the clinic. And also the fourth section is to talk about interpersonal relationships with partners and how to go about the process of disclosure of the HIV status, and building relationships with family and other interpersonal relationships. And also we tend to talk about mother-to-child transmission as part of the group health education. So during the fifth session, so we offer social support as being part of the community and how to integrate with community and how to find support groups within the community for people living with HIV, where we also give education about HIV and lifestyle. So I'm just going to share this brief photo which shows one of the things that we do during the group therapy. So this, we tend to use pictures to get to know what the clients are thinking and to get to know their perspective, and also to have like an open discussion and to break the ice when it comes to having these conversations, which might tend to be difficult conversations to have. So these are series of photos that are shown in a session that talks about where does a client hide their medication. So we just show these photos, but we leave it to the clients to explain these photos of what they see about them and what do they think about these photos. So you can see a photo of like this farmland where a patient might describe that they hide their medication like in a garden, and they just dig a hole in the ground and they put their drug bottle there. And also a patient who hides their drug in like the washroom, and these are articles of clothing where the patient tends to like hide them under the cloth article to make sure that nobody sees this medication. So one of the aims of this session is we talk about how to store your medication in a proper manner and the importance of making sure that the drugs are stored carefully, because different temperatures and different humid surroundings can damage the drugs, and the importance of making sure that the drug is in the bottle in this. So this is one of the things that are discussed in the group support. That I won't go through all sessions, but this is just one snapshots that to kind of give you an overview of what happens during the therapy sessions. So going on with the study, so the comparison group for this study is the standard of care from the historical control. So we are basically comparing patients who have, we have a timeline of comparison from patients who were prospectively enrolled in this study, then we compare with patients who were receiving care at the clinic before the commencement of this study. So, and the outcomes that we look for in this study involves the linkage to care as our primary outcome, which is defined as being in care and on ART at 2 months after the diagnosis of HIV. And our secondary outcomes include retention to care, which is defined as presenting for the first viral load control at 6 months after the initiation of ART, and viral load suppression, which is defined a viral load of less than 400 copies at 6 months after the initiation of antiretroviral therapy, and the improvement in stigma and depression scores. As I say, we do the post-test counseling, which involves the PHQ-9 and the Vargas stigma scale. So we also do it at the end of patient participation in the study, and then we try to compare the scores to see if the intervention has any benefit in terms of reducing the stigma and depression for these clients. So I'll just go through the numbers of this study. I will do a brief run through the numbers. So the sample size that was estimated for this study was to have a total of 321 clients in the post-intervention cohort at the end of 2020. But unfortunately, this timeline was not achieved because we know that was the time that the COVID pandemic started. So we had slow recruitment of the patients, and also we stopped the research temporarily because of the measures to protect patients from COVID-19, and also we also lost some few patients as a result of this pandemic. So due to this, one of the things that we did was to extend the recruitment period for about 5 months to allow us to reach the numbers that we needed for the study. And so the study was extended for 5 months after that. So it was like in May 2021 that was our end of the recruitment period. So newly diagnosed patients at our clinic during this time of the study period were about 520 patients. So these were the patients that we assessed in terms of inclusion and exclusion criteria to attempt to recruit clients. And the clients who were excluded from the study were about 118, which is approximately 23% of the total patients who were diagnosed. The reason that patients were excluded included patients being hospitalized and patients who are less than 15 years of age because they couldn't consent to the study, and patients who are not enrolled at our cohort in Curacao, and patients who are too ill to participate in the study. So these were excluded from the study. So at the end, we had a total of 402 patients, which was about 77% who were included. So during the commencement of the study, we lost some patients, about 87 patients who were approximately 17%. So these include being missed due to COVID, refusals to participate in the intervention, and also missed due to the organization of the clinic, because sometimes we have a lot of patients at the clinic and it's hard to organize patients, so we missed some patients. And also patients who transferred away from our clinic during the baseline visits. So we were left with a total of 315 patients, who is about 61%, and in total is about 78% of all eligible patients. So this is the number that received interventions for stigma. So going to these 315 patients, so the baseline interventions that included the video intervention and the post-test counseling was received by all patients. So we didn't lost any patients for these 2 interventions. And in the mobile health intervention, so we called the patients before the clinic visits at 2 subsequent clinic visits. So we had about 221 patients who were called, received the call, and we had about 181 patients who received the second call. So the reason of it not being 100% included some patients not having phones and some patients not answering their calls. So that is why we lost some patients in the health intervention. So in the group support therapy and group health education intervention, we only had about 96 patients who attended this group support sessions, which is about 81% of the total participants in this study. And the reason behind missing a large number of patients for this group support interventions included issues with scheduling, visits at the clinic. Some patients come earlier than their days that they are supposed to come at the clinic, or some come a little late than their days, and also organizational issues at the clinic. And some patients were reporting they saw the sessions as being repeating kind of sessions. So they didn't see like a kind of diverse topics. That was also one of the things that caused missing of the patients. So patients who did the stigma and depression questionnaire included 347 patients. So the study outcomes. So our expectations from this study include we expect to see these 4 bundles stigma-directed services to increase linkage to care by 10% from 70 to 80% post-implementation of the study. And this assumption is coming from our review of literature of similar studies that address stigma interventions to improve the linkage to care. And we also expect to gain knowledge on the value of stigma-directed services and to observe an increase in biological suppression rates as well as retention to care of patients within the first year. Yeah, so the current status of this study, the study protocol has been published at the Africa Population Health Research Journal, and Dr. Elizabeth is also one of the first author of this study, and she's currently in the room. So if you have any questions, I think we can answer them together. And the window period for the second questionnaires at the end of the study were completed at August this year. And also we are still continuing the stigma interventions post the study, and we will make decisions on whether to control to stop after we analyze the data. So currently we are analyzing the data and we are writing the manuscript for this study. So thank you. That's all.
Thank you, Bernard, for your presentation. And now I would like to invite participants for questions and comments. Thank you. Hello.
Can you hear me? Thank you, Bernard, for your presentation. And I have seen hands from there and there, 2 hands. Okay. We have 3 hands now. So let's start with Claudio back there, and then we'll come to Zahara, and my co-chair will follow.
Yes, hello, good morning. I am Claudio Mtinges. I have interest on internalized stigma among people living with HIV, especially for key population. To me, the presentation is nice, but many organizations and even the government has done a lot of stigma interventions to people living with HIV for many years. So if let's say I see specific for certain group, like let's say yesterday we cut across children's, adolescents. To me, I see the difference between internalized stigma with a certain specific group. So maybe I would like to know from your side, did you focus a certain group or it's just general? As you understand, targets are here. They've been working so much with a lot of stigma interventions. But if we show targets, something like we focus only to this group, they feel like, oh, so there's something that is very unique to a certain group. If we focus, let's say, to key population, they feel like, oh, so key population is not only about biomedical stigma, or stigma due to biomedical interventions or structure or what. So they get to learn more about a certain aspect so that during proposal writings or strategic plan preparation, they are able to add a certain element that is really targeting a certain group of population. Thank you.
So thank you for your question and comment. So for the purpose of this study, we enrolled clients in a prospective cohort, which means all patients who are diagnosed with HIV from this time point to this time point were enrolled. So we didn't necessarily have like specific focus on key and general populations, but one of the things that we do at our clinic, we also tend to assess the HIV transmission risk. So we look at whether the HIV transmission came from like heterosexual sexual practices or homosexual sexual practices or injection drug use. So those are routine data that we collect at our clinic. So I think that members of the key populations were also included in the study, but we didn't necessarily have that specific focus for the purpose of this study.
Okay, my name is Zahar Mansour. Thank you for your presentation. It was nice. Just I wanted to ask, what can we do to improve the issue of self-stigma? Because we have said the linkage is 23%. It shows that the linkage of people to ART is still a problem. Thank you.
Thank you for that question. So mind you, so the data that I presented on this lower rate of linkage was from 2017. So I believe that the current data, I hope that we have better linkage to care at present. But this was just the observation at our clinic during that time that motivated us to, that informed us to take this step in improving the linkage to care. But I think, just to generally answer your question, I think there are multiple initiatives that are taking place to increase linkage to care. And one of the things that we are doing at the clinic is to have these 4 kind of interventions to see whether or not that they are effective. So I think it's a thing that we are currently learning as we go. And I hope that after the analysis of data and after we get information that whether or not these interventions improved to care, then we can adapt them to happen as routine intervention at our clinic.
Okay, thank you for your presentation. Evans, I have some suggestions. The first one, I suggest that you change the word HIV. My name is Evans Gay, as I introduced first. Okay? So I have a suggestion. Instead of use the word like HIV infected, we have to use the word people living with HIV in the context of our topic, just discrimination. And instead of using patients, we use clients, unless they are admitted in the wards. They say, I have one question. On the outcome, you say that you consider the value is below 400 copies per mil. What moved you to take that that number instead of maybe less than 50 copies per mil or 1,000 copies per mil? I mean less than 1,000 copies per mil. Thank you.
Yeah, so the reasoning behind this is that so the definitions of a suppressed viral load varies according to different literature. So we have a viral load of less than 50. So we took a viral load of less than 400 copies because some clients have like a slow virological recovery from the time that they start their treatment of ART. And we don't have the initial viral loads that the patients presented with at the clinic during the time of diagnosis. So we only do the test after 6 months of the patient being initiated on ART. So at 6 months, if the viral load is less than 400, then we can expect to compare it with the repeat viral load and to see whether or not the trend is, because at this time point we don't see the trend, but when we do the second VL, we will know the trend and whether or not that the gland is suppressing or not. So we established a higher cutoff point for the purpose of this study.
Okay. Karibu, my co-chair, with your question.
Yes, Bernard, thank you so much for the presentation. And I believe it's kind of an eye-opener in terms of how we address the issue of stigma. And it is overall a very interesting kind of study. And before I ask my questions, I just wanted to let you know that because of the uniqueness of the study, we'll be having a HIV symposium this December in Lindi during the World AIDS Day commemorations in November, around 1st of December. And we wish to keep in touch so that we can extend the invitation to Fakala. You come and share with us. And then the next question is, I had wanted to know the demographic characteristic of the study participants, because I still believe they might have some implications on the outcome of interest. And in particular, I'm interested if you had these women in PMTCT, but also those who have graduated from PMTCT but are continuing on care. That is one. Number two, whether the issue of gender, meaning male women, also had any implications of on the treatment outcomes, but also including other demographic analysis. Thank you.
Thank you for that important question. So yes, I just summarized this study, so I didn't include like the demographic data, but we also collect the demographic data of the patients. I think maybe when we sit with Elizabeth to review and to update, we can add that information. But the way that our clinic is organized, we have adult clinic, which we see adult clients with HIV, and these include male and female clients, and I think in our cohort, women, the number of women are slightly higher than the number of men who are enrolled. And we also have the same interventions at our mother-to-child clinic, which we call it the one-stop clinic. So we enroll patients from both from both the adult clinic as well as the mother and child clinic. But I think that information, I don't have the complete numbers, but I think it can also be included.
Thank you. First and foremost, congratulations. It's very rare to see a study like stigma in a science, setup, and I think this is commendable job. And thank you, Takis, for inviting the team to Lindi. I think this is very important. You mentioned, of course, this internalized stigma, but there's one particular part that I really want to know how you're going to find out the anticipated stigma. I think it's one of the, when it comes to self-stigma, it's one of the aspects that's really tough to really crack. And I want to know how are you going to measure it? How are you going to not only measure it, but then how are you going to come up with a solution? Because I think if we can get an answer in this particular area, in anticipated stigma, then we are almost 60% towards the solution of solving the self-stigma part. So I wanted to know, what tool are you using? How are you going to, to at least, find out how you're going to deal with it, and what would be the finding? if the finding will be there, then I'll definitely be more than happy to see it and just try to advocate for that particular solution. Because I think anticipated stigma is a very difficult part to really grab. Thank you.
Thank you so much, Dr. for your interesting question. So, yeah, I echo your perspective that it's very hard to assess, especially anticipated stigma, because it's a very subjective value that comes from what the client thinks, and answering it through like a quantitative kind of study, it's very hard because you cannot get like the specific numbers. But I think one of the things that we were thinking about doing is to have a qualitative study that aims at getting the opinions and the views and feelings of the clients themselves about the issues of anticipated stigma. So I think this will be a good tool to at least get the view of from the perspective of the client themselves, which can attempt to highlight the issues with anticipated stigma as opposed to numbers, which is very hard to answer that question.
So, we remain with 5 minutes to our coffee break, so I will take only two questions and then coffee. Thank you.
So, thank you very much for the nice study and findings for the folks at Ifakara. So I have a question. During your study, when you're looking into the stigma issue, did you consider other factors like the client being victims of gender-based violence, client being with conditions like disabilities? Because those are the issues which are compounding apart from the HIV status, IPVs, the infant partner violence, and other form of gender-based violence. Did you do GBV screening and disability screening? Because those are some of the other factors. When we're talking about stigma and discrimination, you need to keep into considerations. And well and good, you are looking into the client stigma, the issue of the stigma. Did you consider also, probably for us as service providers, could be one of among the people who are accelerating the stigma among the clients who are receiving the services? So those are the issues to keep under consideration. I wanted to say so.
Thank you for that observation. Yes, so to answer your first question about collecting data on gender-based violence as well as disability. So normally we collect, we use the GBV screening tool for all patients who are enrolled at our clinic during their visits. I'm sorry, it's very hard for me to distinguish between clients and patients because I'm used to practicing. So, so we collect the routine data about gender-based violence for all patients who are enrolled at our clinic who come during their routine visits. And about disability, we only collect data on physical disabilities. So clients with hearing impairment, clients with physical kind of disability or sensory disability, that is easy to collect upon patient assessment. But to collect like data on the disability on its diverse presentations in terms of visible and the disabilities that are not visible, we don't do that distinction. But I think it's a good note to take into consideration. Thank you.
Doctor, congratulations for your presentation. My name is Bahati Mandago from Integrative Wellness Services Company. I'm a counselor. My question is, I'm very interested to know about the couple counseling. My humble experience tells me like male partners are always very reluctant to know their status, even to attend the clinic. So I would like to know what was your experience like during this couple sort of counseling therapy. Yeah, that's my question. Thank you.
Thank you. So to answer your second question, I think I didn't answer the second question about, I think it relates to what you just asked about the healthcare providers, whether or not there are triggers for this kind of stigma that we see. So at our clinic, so before the commencement of this study, so the healthcare providers who are involved in this study and other staff at our clinic, they received training on issues of stigma and also the way that the study is organized and the expectations of this study in terms to also reduce the stigma that might be unintentional coming from the healthcare workers. And going back to your question about the couple, so during the group sessions, it also involves couples that either serodiscordant couples or, I mean, in layman terms, couples who are both infected, who are both living with HIV, and couples who one is HIV positive and one is HIV negative. So we start with lay counseling, which involves a HIV positive lay counselor who delivers this kind of counseling to the couple. And if upon the assessment of the observations that the lay counselor is having, they can refer the couple to an expert counselor who is available full-time at our clinic for further evaluation. But we also see this in terms of, we also see this as one of the triggers in terms of adherence to care and following up clinic visits with couple issues. So we don't, this is not necessarily organized to give couple therapy, but that can be initiated if it is deemed necessary.
Hello. Okay, thank you, Ben. I'm going to offer Dr. Katanda, the chance to ask his burning question to Ben. And this will be the last question from the participant, and after that we are going to break for coffee.
So
thank you.
Yeah, so for me it's not a question, just a recommendations. So as a country, recently we adopted one of the approach called live approach for counseling and screening the couples if they have gone through any sort of, especially for those one who is living with HIV/AIDS experience of GBV. So the live approach, I think, is one of the best to consider. And for the disability, I will really encourage. We have a Washington tool which we've adapted. In my programs at Gender Health, we've adopted it, and we are pre-testing in 9 regions and all of Zanzibar, in all regions in Zanzibar. And currently we're having discussion with the government so that can be integrated in our HMS tool. It is providing a law for screening all forms of disability which we are talking about. And this is very important because most of the time is a missing opportunity. We do just consider the physical disability, but we need also to consider about disability, all forms of disability because of sense organs, even and the third group is all forms of disability because of neurological effects like Down syndrome. Those are the other ones. And the first one is about cognitive disabilities, learning, intellectual disabilities. And the last one, which is very important for us, is emotional, mental disability, which near agenda society. So the Washington tools providing your room in all settings we can do such kind of screening if it's possible. So for now, we need to pick up and then we can even share the tool. Thank you.
Thank you, Bernard, for the presentations, but also your colleagues and comrades for the comments and questions. But you can still reserve your observations because we will have time for plenary discussions, so those ones can still come up later in the course of the day. Otherwise, we are going to break for tea, and this will be around 2 minutes. So we expect to be back 30 minutes after 10 to start effectively the program. Otherwise, we don't want to spend late hours here like what happened yesterday. But of course, it was for good reasons. It was necessary to yesterday. Thank you. The name of the child
and we can use the tea break to interact and networking